Can we get everyone to make their way back to their seats? We'll start the second part of Dr. Evans' talk. Thank you.
Okay, we're going to go ahead and get started again. I just had kind of a interesting thought. I was answering a bunch of questions during the break, and then Rima pulled me aside and said, "We need to get going, and can you get moving here?" I said, "Well, can I just have a couple seconds to head to the restroom?" So I went to the restroom, and I was walking back, and I was thinking, and there's this. There is this story about this pastor who did that. He actually went to the restroom, and the whole everyone in the church heard the flow of the world. Anyway, so the next talk, we did a lot of the what we're doing in the last talk, and I hopefully you kind of got. I know we took through a lot of stuff, but I wanted to make sure you have cold the context in which we're working, because now we got to work. Now we got to do the doing. So how do we do it? And kind of some concepts about preparing clinicians for the future. Now I'm going to warn you, we're going to start like really theoretical, ethereal kind of stuff in the front end, because I don't know if anybody else has noticed, but this is hard. I mean, the quote of the day is the one that I would pull from Mike, which is, "Don't underestimate the barriers of the work that we have before us." That shouldn't discourage us, but frankly, our culture, we have to change the culture of care. We have to figure out how do we do this stuff. So a lot of this is about figuring out together how do we begin to move down that road. The objectives here, we're going to talk about a discussion around requests and offers a little bit more actually in the next talk. And again, it's about building our network together. Describe the Compass PTN resources and structure. We're going to talk a little bit about what we're going to be bringing you, and I want to talk a little bit about the modified breakthrough series model. We're going to be trying to figure out, with a learning community like this, How do we operate? So I'm going to talk a bit about that. So speaking of the Modified Breakthrough Series model, this is it. You look at this, and has anybody ever seen this before? Okay, this is, you must be a geek. Yeah, there you go. But what this is if you bring a whole bunch of people together and they want to do something different. And what the idea is, okay, we're going to bring everybody together to try to do something we've never done. So, and we're going to learn from the innovation from everyone who's participating how to do it. So what you do is say that over at this end, we want to try to have some new knowledge that can be presented someplace. So how do we assemble folks to do that? Well, what you have to do is you have to select the topic, and then you have some people who can talk about it, and then develop some framework about how you're going to do the changes and what are the change packages. So it's kind of, here's the content, here's all the resources that we have. We brought everything together to be able to execute with a group. Well, you also have to recruit the group. So you have to enroll the participants. That would be you. And then you have kind of some pre-work. And you've done some pre-work already, and you've already done a bunch of stuff just being enhanced. And now you've actually come together today in a learning session. Okay, this is a learning community, if you will. This is up there, it says LS1, Learning Session 1. And you're getting content today. You're getting stuff. You're having your brain stretched. You're having your context moved a little bit. You're getting equipped. But then you're going to have to go home. And then you're going to have to do stuff. Okay? And what you're going to be doing is you're going to be in what's called an action period. Between the learning sessions, Learning Session 1 and Learning Session 2 next year, you're going to be in a period of action. And you're going to be doing PDSA cycles, that PDSA, that plan, do, study, act cycle, repeated cycles of how do we do this here, how do we do this here, how do we do this here. What is the measure that we're going to take as we do this? And now how do we do that? How do we make it better? And we're going to do our run charts. We're going to figure out how we do that. And then we're going to come together in a year, and we're going to have Learning Session 2. And then we're going to do another action period. But this is the whole concept of, and actually, a lot of this learning session is like us setting context for you. We're pouring junk into your brain. Our vision for next year's learning session will be much more of you telling your stories. How did you do that? We're going to be identifying exemplars, who's really performed well. How did you guys do that? Tell us the story. How do you do that? You need to realize that after this meeting, a lot more of the stuff is going to be about how we're going to start salting each other's story as we go forward. So this is basically, we call this the Modified Breakthrough Series model because IHI uses this in a very short-term model to kind of do like over a 4-month period, drive rapid cycle change. What we're trying to do is together learn how, we're using this methodology as a collaborative community to try to figure out how do we do care differently in our state. Okay? Now, you're not as smart as you think you are. As a matter of fact, it's back to the statement that Mike made earlier about never underestimate the barriers, okay? We think we have the context, and honestly, the fact is the matter is we don't know what we know. What we don't know what we don't know. We think we do, but we don't. And you're going to find as you walk this road, the more you do this, you're going to go, oh. Now, by the way, you're going to find things like, well, this doesn't apply to us. We couldn't do this. It doesn't mean it isn't going to happen to you at some point, okay? So I just want to keep this at a very high level right now and kind of talk about how we learn and what we should be doing. So we don't know what we don't know. There's anybody ever heard of Brent James? James is the Chief Medical Officer for Intermountain Health System. He's a national speaker, but he basically, and he's a performance improvement expert, but he has this nice little quote. He says, knowledge comes in 2 flavors. There's the knowledge that and the knowledge how. Knowing that a bicycle has 2 wheels, a seat, and handlebars, and a foot pedal crank, for example, stands in sharp contrast to the practical knowledge of how to ride a bike. Okay? We know what value-based care looks like. We think. We know they're going to pay us for population management. We know we're going to have to work together differently. We know we're going to have to track certain things. We know that there are going to be specialty-specific applications to the different populations we do this. We know those different pieces. Can you ride the bike? Can you do it? We know all of this stuff, but can we thrive and survive on step 2, 3, and 4 of the ladder? Don't know, okay? Now, the interesting thing is, we're going to have to ride the bike, but just to stretch your brain a little bit farther, you not only have to ride the bike, Mike's going to like this, but you got to go harder, okay? We aren't just called to get on the bike and keep from falling over here, folks. We're being called to take risk. We're being called to treat this as a sport. We're going to have to go farther, faster, thinking about timing, thinking about endurance. We're going to have the right equipment, and we're going to have to figure out how we go forward in this. It's a completely different deal. It's a completely different sport, okay? So with that, how do we do that? How do we do something we've never done? We don't even have a concept of how we would do it. And I'm kind of back to the Richard Deming comment. The Dr. Deming thing about performance. Dr. Deming had a very interesting quote that I want to kind of run you through this. Systems create aims. This is the way we really kind of talk about our world. Systems create aims and then measure results. Does that resonate with anybody? We're all in a system. We're all in a complex adaptive system. We have complex systems. We know what we're going to do. We know what our charge master looks like. We know what the process of putting people in the office. We know how we take care of these. We know what the CME tells us with regard to evidence-based medicine. We know all this junk. That's our system of care, and it generates results. And what are the results? How many charges do I have? How effectively am I doing this? How many CME credits did I get? Which proves I'm a good doctor, by the way, right? I take my boards. That proves I'm effective at management, right? Probably, but your boards are really meant to identify, well, this guy at least meets the minimum standard that he's not going to kill people, okay? It doesn't mean that you're going to excel in that process. But we have systems, and basically systems create aims and measure results. This is what you're all familiar with. If you map this out, if you look at like over time, and if we had to increase the value of what we deliver, we say, okay, we just want to increase it a little bit. The first thing you're going to go is, well, I don't have enough resources to do that. I need some more resources, whether it's more people, more money. It usually translates into more money somehow. So I could probably increase it without an infusion, but I'm going to have to work harder, okay? So what happens is we go with the same amount of resources and we work harder, or we become more sincere or whatever, but we just do what we're doing harder, okay? Everybody with me on that so far? This kind of feels like our world. What Deming came back and said is, yes, that is the world, but it is wrong if you're going to change things. If you're changing all the rules, your complex adaptive system is actually a barrier to changing. And he made the point, he says, systems don't create aims. The aims create the systems. Every system is perfectly designed to get the results it gets. Well, if you want different results, you're going to have different systems. Kind of makes sense? We have a volume-based healthcare system that has worked for us, but now we got to do a value-based healthcare system. Well, what are we going to do? Value-based system means we got to have dramatically better value. We want to try to get to value that's off the charts, and they're going to figure out how to pay us for that. But the question is, how do we get there? Oh, well, we'll need an additional cash infusion, right? Wrong. There isn't an additional cash infusion. They aren't going to print any more money. We're going to have to figure out how we do this differently. Okay, so we have to do it differently. How do we do it? Don't know. We're going to have to figure it out. We're going to have to figure it out together. Matter of fact, figuring it out together means there's got to be a path to get there, and we're going to have fits and starts as we move forward, but we will figure out the new path to get there, and that's really what we're doing. This learning community concept is we together are going to be sharpening each other's saw as we get there. Now, right about now, you should be going, right. I can't. That's wonderful quality improvement, gobbledygook. That's just great. No one could ever do that, right? No one could ever do that. Ever seen this guy? Okay. I just want to remind you that our country actually did this. This is an example, pretty good example of this, is the United States Space Program. In 1961, April of 1961, President Kennedy issued kind of the challenge. He said, okay, we're going to put a man on the moon by the end of the decade, in the United States. Now, you need to understand, because there's a few of you that have gray hair in here that were alive at that time, and may actually remember that, but the state of the space program in 1961 was not good. He couldn't just roll out, just kind of call up NASA and say, hey, just go roll a Saturn V out there and let's get to work on this thing. Kind of tune it up a little bit. And let's do it. It didn't exist. Matter of fact, in 1961, there were two primary competitors in the space race, the United States and Russia. And Russia had Sputnik. Now Sputnik was a satellite that was about this big, had 4 antennas sticking out, and it was circling the Earth. And it was at that point, you realize, you have to think back, there wasn't anything else in space. Maybe rocks, okay? But there were no other satellites, it was just Sputnik. And the Russians had put this thing up there, and it was very intimidating. They could drop stuff on us. That was kind of the idea. There was a kind of a hue and cry in American society, is that the Russians could do this. If they could put that up there, they can drop stuff on us. And you know what the American space program? We didn't have any satellites. Not only did we not have any satellites, about 40% of our rockets just blew up. Okay? So we couldn't even get stuff into space. So for Kennedy to respond to this was a huge step. And we initiated a series of things that actually took us to that point. And the first thing that happened was the Mercury program. There were 7 flights where we had to create a tin can that one guy could live in. We had to create an environment that he could survive, and we sent him on the back of a huge explosive thing, and we sent him into space. Anybody remember the first astronaut? Alan Shepard, okay? Anybody remember what happened? What was salient with his flight? There were 2 things. Number one was that he was the first one to go into space, but what he did is he went up, and then he came down. And then they fished him out of the ocean, and they fished out the capsule, and everybody celebrated. We've got our first guy into space. That was the first thing. The second thing that was salient that most people don't know is that he sat on the pad for so long that he had to empty his bladder, and he couldn't, and they almost canceled the flight, and finally he had to get special permission to wet himself while he was on the pad. And that was just something for you to think about. And all it did was that he shorted out his cardiovascular system. They couldn't monitor his heart rate when he did this, but that was the only thing. So it's just kind of an interesting. I'm a doc. Things like that are just kind of a little sick, but anyway. But then, okay, so great. We put somebody in space, and we got flight number 2. Okay, so we put him on the pad. Gus Grissom. We put him on the pad. We send him up into space. We bring him back down, and we didn't succeed. We pulled him out, but we lost the spacecraft. We weren't successful the second time, okay? Third flight, anybody remember that one? John Glenn? John Glenn. Okay, John Glenn. And anybody remember what was important about John Glenn? John Glenn orbited the Earth 3 times, okay? Big whoop. And then we landed him, and we were able to do it. We had 4 more flights from the Mercury program, and then we decided, okay, let's go to the next step. And we had the Gemini program, 2 people. You got to have 2 people in space at the same time. That was unique. The other thing we had to do that was unique with that program is we did spacewalks. So we had to depressurize the capsule, open the door, let them hang around outside, close it, and repressurize the capsule. Okay? There were interesting challenges that had to be done with that, and obviously the pressurization and all that stuff, but you've got a waste management system when you're up there for 14 days. How are you going to manage all this stuff? It doesn't just go up and come down, okay? Then we go to the third one. It was the Apollo program. We're now doing 3 guys, and that's preparation for 2 guys to go down on the lunar module and 1 guy to stay in the capsule, but we had to have 3 guys, and all those problems accelerated, and by the way, we killed the first 3, okay? Apollo 1 was a flash fire, and killed the first guy who walked in space and some other people. But we failed. But eventually, by 1969, we achieved our goal. We had an aim of putting a man on the moon by the end of the decade. In July of 1969, I believe July 21st, we succeeded in that. So why do I tell you that? Because that's sort of what we're doing with American healthcare today. We've got to figure out how we're going to do something, and there will be fits and starts. There will be questions where people say this doesn't apply to us. We've got to figure out how we do this. But we're going to have to, we've got to bend the cost curve. We've got to improve the health of our population. We've got to figure out how we're going to do this. AIMS creates systems. Got that one. But then the systems themselves go back to creating results. We're creating new systems. It's kind of back to that concept of now that we have the aims of a value-based system, and we're going to create new systems, and now we're going to have the new metrics and how we figure out how we go forward. That's what we're doing together. So that's really where I'm going to go from here. So all of a sudden, the Breakthrough Series model takes on a little bit of a different feel. We got to put a man on the moon. We don't know how to do it, so now we got to figure out how together are we going to do this value-based thing in Nebraska. And that's why Compass is here. And I guess I made the point, about Nebraska, but we're one PTN. There are 29 PTNs, but you've got the same thing going on in Iowa and in Georgia and in Oklahoma. And I don't know why in this slide Nebraska is blue. Just notice that. And then, so the whole point is we have all of these other places that are innovating at the same time. And we're going to be, and here's another, just an interesting observation. In Compass PTN, all of our environments are rural. Do you think that the rural environment is a unique application of value-based care? You betcha, okay? Low volume, high distance between providers. There's a unique application. We've got to figure out how we do this. The feds can go and change all this junk, but we've got to figure out how we can execute it in the rural environment. So, I just want to touch on, spend some time talking about the patient-centered medical home and remind people, how many of you are a patient-centered medical home? Okay, and how many of you, you've been working on this, you've been working on this stuff since 2008 or something, okay? I just think it's important to realize the journey of the medical home because it really, well, let me go through it. Where did it come from? And many of you have heard this already, but it's not a unique piece. It's not a new thing. It was actually introduced in 1967 by the pediatricians, basically for the care of high-risk children. When you've got broken kids, congenitally broken children, they end up with all kinds of multiple specialists, and it was the need that was identified that someone's got to coordinate this care. Someone's got to coordinate all these different activities, a center place, a home, to kind of bring this information so we have coordination of this entity as we go forward. And it was good. It kind of kicked along and stumbled along for management of children with multiple problems until around 2002 when the pediatricians are saying, we got to tune this thing up. There's got to be a better application of this. And they actually, it was about the same time that Ed Wagner has brought out the chronic care model. So they were kind of trying to figure out how do we take some of these models and mush them together and upgrade the model of the medical home. The concept that there's a primary care entity that assumes responsibility for coordination of, and taking the coordination beyond just coordinating specialty services, but now coordinating of life services. So you've all seen the chronic care model. I do want to make a point on the chronic care model. Think of your community. Today, right now, everything is so siloed. And what we have is in our communities, we may have some healthcare resources in the health systems piece. Think of that as the medical neighborhood. But you've got to have this prepared, proactive practice team. I don't care what specialty you are. You could even be a surgeon, as far as I'm concerned, to be part of a prepared, proactive delivery service team, engaging with a different patient than we've dealt with in the past. A patient that's prepared, a patient that's informed, and a patient that actually gives a rip. They're activated. They're your partner in care. Only through that are we going to get those improved outcomes. And that's usually where we live, and most of you are providers, but the fact of the matter is we've got to figure out how we take this out and deploy it now as a community. So there are 4 touch points that we now need to think about as we go back and deliver care. How do we engage our patients and equip our patients differently? Our care unit that's delivering that intimate care with the patient is another thing, but how do we work up within the medical neighborhood? And it's how does our medical neighborhood work with public health and the Area Agency on Aging and all those other things? I know this sounds very public healthy at this point, but we won't be able to achieve what we can achieve unless we start thinking of it in that way. Today, with MIPS and all the stuff we're working on, we're focusing on basically the box that's prepare proactive practice team. How do we tune our fiddle to be the most effective we can there, but know that we operate within that bigger venue. So the pediatricians began to kind of work and bring together some of these other models, the primary care model, the chronic care model together and smush together. They were working to come up with some new concept of the medical home, and the family physicians and the internal medicine docs, and they all kind of came together and they agreed on a set of joint principles for what the medical home should look like. So in 2007, Peds, Family Medicine, Internal Medicine, the Osteopathic Association came together. This has now been endorsed by 40 medical specialty organizations. And these are the joint principles of the patient-centered medical home. And really, the reason I'm talking about this is that for us to do value-based care, this is like where you start. Now, for a lot of people, I've said, the patient-centered medical home is 40% of what we have to do to be successful in the value-based model, but it's the first 40%. Okay, so you need to be thinking about how you embed these things. Personal physician in an ongoing relationship, I basically would reframe that one accountability. It's no longer that you're just here to sell office visit units. You basically have an accountability of how effectively that's working. Physician-directed medical practice team, it's a team sport. It's not that the doc can do everything anymore and everybody else is there to kind of help them do everything. We've got to be thinking about organizing our teams into teams. Who does what? The doc can't do everything. Matter of fact, the doc shouldn't do everything. We need to be offloading what we can from the doc so the doc's going to work on the most complex, the ones that need the most resources. They need to manage the highest risk patients and let somebody else do some of the other stuff. A whole person orientation, rather than just taking care of their blood pressure, but thinking about the whole orientation. What else is going on in the patient's life that could be influencing / sabotaging your effectiveness of controlling their blood pressure? Coordinated or integrated care across the system, that goes back to that chronic care model. We got to figure out not only just how do I work with the other specialties, but how do I work within the entire, remember one of our goals is to reduce hospitalizations. The hospitals, that's one thing, but we also need to be thinking about how do we work with our communities differently. Here's one. How do we work with our pharmacists differently? Do you realize what a powerful ally they are with regard to compliance and actually medication use? And medication, there's medication safety and medication effectiveness. The pharmacists are powerful allies in helping us with that. Quality and safety are a hallmark. You can't do that without data, folks. We've been trying to for years. So you basically need to start having that dashboard of things that you're tracking and that you can prove what you're doing. And now CMS has given us PQRS. We have the test. We need to start teaching to it. Enhanced access. One of the big premises of the medical home is making sure that we make sure that they have such good access to us that they won't automatically default to the emergency room for little ditzy stuff. Okay? Now that's one of the things that you can manage, but the fact of the matter is we need to assume that responsibility, okay? Enhanced access. Now the first 6 are all like yada, 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 yada. We need to do this stuff. We got it. That's what we can do. And then the last one is, and they're going to pay us in a way that recognizes value. Realize that the chapter has been from 2007 when this was written. We're going to go do all this stuff, and the payers have said, and we'll pay you differently, but you have to justify that you can do all that stuff. So we've ended up with the different levels of medical home, the payer community trying to get us to jump over certain bars to get there. And we've had this, medical homes kind of become almost like I don't want to, this sounds bad when I say it, but almost like a religion or something, and people are, until it's like I could do this, but until they pay me to do it, why would I invest completely in any of those resources, okay? So that's kind of where we've been with medical home. Lots of energy and then just kind of okay, kind of a thing. And awareness, we should do that, but they're going to have to change the payment methodology, right? They just changed the payment methodology. Okay? Your world just got rocked. With MACRA, all of a sudden this becomes extremely relevant. Okay? Metrics, quality and safety, that would spell PQRS and meaningful use. And now they just did this for Medicare. They just said, Medicare, we're going to change the payment to do this model. Okay? So if you didn't get anything else, medical home's 40%, but it's the first 40%. So figure out how you're going to start embedding some of those skills that first deal. It's important to remember that the medical home can help us with a lot of pieces, successful transitions to the hospital. Marty is going to talk, Marty Hatley is our speaker this afternoon on person and family engagement, but the medical home concept really helps us develop a relationship with our patients so that we're credible with them and helping equip them for the future. They need to know how to use healthcare resources, but they also need to become very skilled in self-management. And what we tend to do on self-management today is send them to a class, go do a thing. We're going to have to figure out how we do that. You do it, we need to figure out how we do it better going forward. And finally, the medical home can really serve as a lead in creating coordination of community resources. I want to just kind of a little bit of terminology here that medical home. What's the medical home? It's not a single place. It's not think of the medical home not as the noun, but as the verb. It's an action thing. So it's a single concept of healthcare delivery that's structured around a patient's needs. Remember, we're supposed to be patient-centered. The care is accessible and comprehensive and coordinated and focused on quality and safety. And this is from ARC. So that's the medical home. The next concept introduces the medical neighborhood. The term medical, it was very hot when we're talking about medical home, and then the academics got involved and said, well, you know, they've got to operate within a larger medical neighborhood. So Elliot Fisher coined this. It is basically looking at that medical home has to operate within a larger world of things. And the medical neighborhood describes the integration of different healthcare providers within all these pieces. Now, a lot of folks will camp on it's about the medical neighborhood. I will tell you that's pretty important for us to be working on care coordination, reducing readmissions, and all that kind of stuff in the medical neighborhood. But I'm also going to tell you, you don't have a medical neighborhood if you don't have the medical homes. I've had a lot of people putting a lot of effort into creating organization around this stuff, and they have inadequate preparation at the medical home level. So just be thinking, depending on where you are, how do you work on the joint enhancement? You've got to have those prepared and proactive practices, executing care in a different way, but we've got to have an integrated model where we're working together. So that's medical neighborhood. An ACO, it's an ACO, it's a provider-led, watch my mouth, provider-led organization. The mission is to manage the full continuum of care and be accountable for overall cost and quality of care for a defined population, as opposed to a MCO, a managed care organization, which is a payer-led, okay, insurance company-led organization whose mission is to manage the full continuum of care and accountability and overall cost and quality. Now, provider-led, payer-led, taking risk. Who gets the dollars at the end of the day? Insurance company or provider community, okay? The managed care era of the 90s, when we couldn't really manage quality very well, they were at risk. And they were creating incentives and payment methodologies and things to kind of incentivize us to do things differently. We've been jumping to their pork chop for so many years, okay? Where we are today is we have an opportunity now as the provider community to actually assume risk and figure out how do we do this different, okay? Problem number one, we will be at risk. With the risk, there is a risk or reward opportunity. Probably the most important piece about the ACO, though, is who delivers the care. Who at the end of the day says, is this good medicine? Okay? So I think the provider community basically is not incented to do things differently. They're incented to design things differently. That's our opportunity. I'm a strong proponent of the ACO model because it actually incents redesign of the system to a more sustainable point. Okay? The MCO, my state just went managed care for Medicaid. You know what that says? That's basically, we give up, we can't do it, so we're just going to give somebody else the risk, and the state can say, okay, this is our fixed dollars that we're going to pay for Medicaid, and now it's your problem. So the provider community is trying to figure out how they're going to react to that. So again, that's the ACO, okay? Now, the medical home, this is an interesting quote from the Aetna Foundation, one of the payers. At the center of integrated healthcare delivery is the high-performing primary care provider who can serve as a medical home for patients. On the Elliott Fisher graph, or the picture of all that stuff, he's basically saying you can do all of this stuff, you can bring everybody together, you can align the hospitals, you do all this junk, but unless you get that prepared and proactive unit to actually have the relationship with the integrated and prepared and activated patient, you're not going to be successful, okay? Not that you should feel important or anything, okay? So, just a couple of quick, these are older slides, but they're basically, they demonstrate that there have been a couple of studies that are out there trying to say, okay, we've done the medical home, but does it really save? Does it really do it? And it's really hard to get a large enough N and a large enough stuff to actually, in these pilots, to prove that it does or it doesn't, and it does. A study from Colorado showed some significant improvement. There's also the Nebraska study, significant reduction in ER utilization, medication and effectiveness was improved, and the patients liked it, the providers liked it. So it basically, the model does work, but we haven't rolled it out because we haven't really had the sustainability strategies for it, and now we do. And the feds are committed to it through the MACRA. So this is just another effectiveness study that showed that there's a significant impact in cost of care in 60% of practices. I think it's just a caveat on the medical home, though, and I believe it was in this room, Don, in March. There was an AAFP conference on medical home. There was an interesting quote that was out there. Somebody said, we were talking about medical home, and they made 2 points. They said, number one, in deployment of the medical home, it isn't like you just turn it on and you are one. It takes between 18 months and 2 years to develop the capability to the point where it's mature enough to feel like you're actually doing it. It's a dance. You got to figure out, you got to get the resources, you got to get people trained, then you got to get them to do this stuff, and you got to practice. It's like putting a football team together. Everybody's got to kind of practice a bit before you're ready for Friday night. So it takes about 2 years to get to the point where you're effective enough. And the other thing is, and how do you know when you're there? And a wise old family doc stood up and said, you are never there. Okay? The thing about the medical home is it's like one living PDSA cycle. You're constantly improving as you go forward. So it takes about 2 years to develop base capability, and from that point on, you're off to the races, continuing to evolve. Okay? So, here we are. Why are we here? Okay? You're all going, I'm getting sick of this guy. Why are we here? Well, we're here for TCPI. Basically, we're here to try to take you, we're going to take you through the 5 phases of transformation. You've seen this slide before. And I was kind of talking to my staff, and we said, okay, what is CMS asking us to do in this TCPI project? Okay? So it's really these things. A, we want you to move toward a patient-centered medical home model. Now, that's a nice way of saying there are skills, get about the business of deploying them, develop expertise in using those. We want you to begin to measure quality if you're not doing it now, but you need to start doing it. And it's not like you gather quality data and you look at it about every 6 months to see how you did. This is about looking at your quality data, having processes identified, and starting to look at the processes on a regular basis. I can't tell you how many times over the last 20 years I've been involved in situations where people say, oh yeah, we've got data, here, it's right over here. They don't do a thing with it. That's our biggest problem. That's your biggest challenge. Getting the data and using it. You need to assemble a learning community. This is our first effort in bringing this together, but you're going to be interacting with each other as you go forward. And to do that, you got to get on board, but it's one thing to sign up. You're all signed up. But now you got to engage in this process, and then you got to go do the hard work of transforming. And again, we're going to, through that practice assessment tool, we're going to be assessing you on your journey. This is your journey as you go forward. Now, I need to talk to you about 2 components of the TCPI program that are going to kind of define our work together. One is the change package, which is a body of information that basically will kind of coach us as we go through this. It's national content. It's been in development for about 1.5 years. It's just recently been released. It aligns with another piece called the practice assessment tool. So I mentioned the practice assessment tool earlier. What you're going to do is you take an initial practice assessment tool, and then about every 6 months, we're going to score you again, score you again. And the way these score is it will identify opportunities in your score that link tightly with the change package. So we can find those resources and bring them in and help you kind of improve over the process. So don't get freaked with a practice assessment tool. That's actually your friend. Think of it as a survey that tells me, okay, where do I need to work on stuff? The change package will bring some of those resources. And the change package, by the way, so what's in the change package? Like, what do they want us to change into? What are the components of value-based care? The change package basically is organized, it's organized into a goals and objectives and then tactics section. And your practice assessment tool will give you kind of how you get into those. But it's interesting when you look at how this thing is organized. So there are 3 primary goals in the change package, okay? Number 1 is to enhance person and family-centered care. Remember the first thing that Berwick said was it's about patient-centered care, okay? This has got to be about the patient. So there's a whole section here about how we do that. The second piece is providing continuous data-driven quality improvement. And I pounded this multiple times today, continuous, every month. But you've got to be using that data to look at your cycles, look at your processes on how you do them and saying, well, what if we did this different? And then look at that for about 4 months and see if your data improves. And then the last piece is, and this is the one everybody wants to know, is so how do I stay in business? And this program is actually going to help you try to identify ways that we can create some operational changes that will help you maximize, to quote, thrive in value-based reimbursement. So I want to spend a little bit of time talking about each one of these 3. So with regard to person and family-centered care, that's me, the one on the left. And this is in Hawaii. And my wife and I, about, 5 years or so, we were on a trip to Hawaii, and I was goofing around, and she took this picture, and I was kind of, as I was looking at my holiday or my vacation slides, I was thinking, you know, that slide is that just says a lot about person and family engagement. Like here I'm talking to my patient. Now, number 1, I really don't hear them, and they really don't hear me. But I'm acting like I'm doing it really good, you know? And I guess I just would kind of, you know, this is sort of like you don't know what you don't know. We talk to our people, but do we really create effective mechanisms for moving? And that's one of the challenges. So I really, we have a conference that we do every year on patient safety in Des Moines. And so one year, and I was really, really moved, and I really am, patient and family engagement is really important to me. So I still remember we had this panel discussion, and I'm feeling pretty good about my expertise in patient and family engagement. And so we brought 2 hospitals in that were going to talk about their patient and family engagement strategies and how they were advancing that locally. And we also brought in a patient, and the patient was actually from one of the patient and family engagement councils in Omaha, to be honest. And so what happened is the person from one hospital got up and they talked about their wonderful plan, and it was all great. And then the second person got up and talked about, it was actually Eric, it was Mary Greeley. So we were kind of talking about, you know, they were talking about their wonderful patient and family engagement strategy, and it's all great. And then the patient got up. And I'm actually so proud of myself because we have a patient up on our deal. You know, we invited the patient to come in and talk. So this patient gets up there and this guy's talking, he goes, you know, this is really important. And I just want to thank you guys for inviting us to your provider meeting. But you know, we as, these were great presentations, but I just want to say, you know, we as the patients, we see things differently than you do, and we're really a powerful tool to help you. And you don't know what you don't know. You don't see the things you don't see. And he says, you know, and by the way, this is just a great meeting, and I just love that picture that Dr. Evans has up there. And he says, by the way, but we do see things that you don't see. Like, for instance, did anybody else notice that Dr. Evans has 3 legs? And I'm going, what? And you know, and it was a wonderful metaphor for, well, they see things we don't see. And that's really the point I'm making on this is we got to develop whole new skill sets around patient and family engagement as we go forward. That's one of the reasons we have the national speaker, Marty Hatley, coming this afternoon to talk to us about the whole science, and it is now becoming a science of person and family engagement. So these are the different objectives in the goal of person and family-centered care in the change package. So this just gives you an idea of the things we need to be working on. Obviously, developing the whole skill set of person and family engagement. We have to be working locally on our team-based relationships. How are we going to manage populations? How are we going to engage the practice, not only as a practice, but as a community partner in how we execute care? Working on care coordination, and then enhancing the access as we go forward. So that's person and family-centered care. With regard to performance improvement, a continuous data-driven quality improvement strategy. Again, you've got to have, I can't stress this one enough, this isn't just about gathering data. This is about leadership, okay? Now think about that for a second. You know, if you don't have your leadership engaged, how much do you get done, okay? What's the primary job of leadership in this situation? It's not to do all the work. It's to remove the barriers so the work can be done. It's to identify that, it's to set vision and try to help people figure out what needs to happen. We often don't know how to do that. So we got to figure out how we do that. That's part of what we're going to help you with. We want to develop, you're going to have to develop a transparent measurement and monitoring system, and then we want to optimize your use of health information technology. Remember the last goal of this is the goal of sustainability. So for your business options, strategic use of practice revenue. How do we use, all of our revenue streams changing. These don't come from here anymore, and we've got some other stuff over here. And I mean, so there's going to be some coaching on how we actually begin to try to figure out how we do this differently. Workplace vitality, joy in the work, capability to, you know what? That sounds, again, real soft and fluffy. I got to tell you, where the answers are going to come for your clinic are not from the top. They're going to come from your employees and from your patients on how we do this differently. And if your place is not a happy place, people won't feel safe to say, I see these things. We can't do this, probably, well, you know, they're not going to, hey, they don't want to listen to me, I'm just going to sit here and do my deal, okay? So you've got to have joy in the work. Capability to analyze and document value. Whoa, value? What do you mean value? That's that back x-rays thing. That's like, how effective are we really? You know, it's like right now in the volume-based system, we're paid to generate widgets, and we get paid less and less per widget. Now what they're going to do is they're going to start paying us for widgets that work, effective widgets, okay? We're going to have to figure out how we do that. And then basically some coaching on efficiency of the operations. So this is where we're going. The practice assessment tool, the thing that, and again, I've already said this, but you should be doing the practice assessment tool usually within 60 days of your enrollment, and I believe where we are now is that we've got to have those completed, all of them across the whole network by the end of June. So if you don't have it done, get to work. It aligns with the change package, defines improvement pathway, and it basically coaches you. It gives you your track on how you're going to improve, and we're going to do this every 6 months. That's where we're going, and that's the end of that presentation. So, good, right on time. Told you. So, questions? Yes, Eric? Yeah, a good question. Well, it's a huge project. This is probably more budget information than most people would want, but I'm going to give you a real quick cut. It's about $600 million, but a piece of that, what we care about is the piece that went to the practice transformation networks. So only a piece of that went to the practice transformation networks, number one. Okay? So there's some to the SANs, but then there's some to the QIOs for doing some measurement stuff, and then there's some for an evaluation contractor, and there's some for the content contractor who was developing the change package. So all of those different pieces were components of the program. For our segment on the Practice Transformation Network, there are 29 Practice Transformation Networks. Just because we're the second biggest doesn't mean we got the second most money, okay? So, as a matter of fact, what happened was there were 29 contractors. Each one of the contractors submitted an application. So I don't even know what everybody gets, but I know that what we got, we have a slice that's a little less than 30 million, okay? Now you're all going, 30 million? Well, divided by 4 years, divided by now 10 states, okay? And every one of our states has a specific budget that's been done. And now that all sounds really good, and then you have to kind of go with the last piece, which is, this is a time and materials contract. So whatever your budget is, that may be your budget, but you have to spend the resources to be able to draw on the resources. There's nobody getting rich on this. Okay, so the whole point is if the dollars aren't spent, the dollars aren't spent. So what this encourages us to do is to develop the resources to bring out to you. And so that's why we do have a top on how much resources we can bring to you, but the biggest question at this point is, what do you need so we can bring that to you? So our partner here is Enhance, and Enhance has done a great job in trying to lay out the infrastructure to execute this deal. Does that kind of help?
Does not offset 4% or 7% of Medicare does not offset the costs to invest in the resources, whether it's technology
Yep.
or whether it's care managers or health coaches or any variety of people that actually helps us deliver that care better. And so unless we're getting kind of funds from or help with seed money to figure out how to do this to get started, it's going to cost us more money, and that, for Brian, that means more subsidy. For private practices, it means, frankly, docs take home less income.
Yep. And I guess my response on that would be, in a static world, it's absolutely true. But the federal government has basically said, and frankly, as the federal government goes, the commercial payers are doing the same thing. They're moving from the volume-based methodology to a value-based methodology. So the whole point is, we can sit here and say it's never going to change, or it doesn't make any, it's sort of like saying, if you got a foot in two canoes, when are you actually going to put your weight in the other canoe? And I know this is the one that's got you here historically, but at some point you're going to have to decide when you're going to do this. The canoes are starting to separate. I can't tell you when you do it. I can tell you that I can bring you resources to help you prepare for this, to be in this canoe, and that's why we're here. I can tell you I'm 100% confident that we're going to this canoe. Now the question, and now that doesn't mean that all of the ways that we would get there have been figured out. And my biggest challenge with bringing together the Compass PTN, like I said, there's 29 other PTNs, but there aren't any that have the same kind of a rural representation that we do. And one of the reasons that you need, that I'm happy you're here, but one of the things that really drives Compass is, we receive this stuff from the feds, but we bring stuff back to the feds. And one of my messages is, you're going to kill us. These are wonderful strategies, but how's it going to play in western Nebraska, or in South Dakota, or in, so we've got. I think we have a responsibility communicating back what's not working as well. So again, I'm not really answering your question other than saying that's going to be your decision on when you want to decide you want to pull the plug. I would strongly recommend that you start developing those skills, and I would also strongly tell you that it looks like the timeline has been accelerated in moving that direction. So the other thing is that, so what does it cost you to be in Compass? Nothing. Nobody had to buy anything to get here. Marty?
I'm just going to jump on this gentleman's question, because I think, Tom, you said it, we're going to have a chance to have a two-way dialogue with the feds. They're going to be looking at what works from community.
Go the mic, Marty.
Oh, sorry, Rima. they're going to be looking at what works coming out of communities like this. Tom and I have worked before in the Partnership for Patients campaign, and we would joke that it was an up and out strategy. We would find the things that would really work. We'd bring it up the silo, across the platforms to talk about it. So if there is something about the patient-centered medical home that really is that first 40%, that really is reducing readmissions and the other things that the feds care about, we should be able to tell that story in a way that, you know, might make them look at how they're supporting patient-centered medical homes over the course of the 4 years, I would think. Would you comment on that?
Well, yeah. Well, first of all, the feds have already bought into the medical home model. It's just kind of, it's embedded in so much of the philosophy of what they're doing. But I don't want to leave you with the impression that this is all just about medical home. Okay? The medical home is a wonderful model to help you begin this journey. But and it's a construct, again, 2007, and it was really the medical home model. The construct was, how can we do primary care differently so that we can thrive in a volume-based healthcare system? Think about that. Remember the seventh piece there? And they'll pay us to reflect this value. Okay? And Eric's point is, and there's not enough money to justify this additional cost. Right? That's really what you're saying. And the point I'm making is that's right. In this canoe, that's why it hasn't really taken off and become all wonderful, but there's additional pieces going forward.
Tom.
I got a hand up in the back there too. Oh wait, Mike, did you have a follow-up there?
I think that's a really important question, and to provide some clarity from Tom's PTN perspective, the Compass PTN, you know, what funds are flowing through Enhance and what have we done with those funds. I'll just tell you from the beginning, I think we recognize that what we're asking people to do demands more resources than we were able to acquire with the grant. It's an insufficient amount. It's a beginning, an initial step. And it does give me, I wholly agree with Tom. If you think about the journey we're on, particularly through a primary care lens, we're all going to be having a team-based, continuously improving, data-driven, patient-centered model, call it the medical home. That's the path we need to go on. But I would back you up even more for the TCPI and say, you know, really, we're going to begin much simpler than that. And for that reason, we're not trying to populate or create patient-centered medical homes with the TCPI grant today. We're just trying to get people to begin the journey. Enhance receives, I think our budget was about $1.8 million this year, and that has been used to employ 10 quality improvement advisors, a project leader, and quality improvement expert, and a data analyst, and to host these conferences, including some travel expenses. And also it serves to support some other enhanced positions. And when you look at it through that lens, $1.8 million sounds like a lot of money, but you realize that gets eaten up fairly fast. It's not just salary, but it's overhead and indirect expenses and all that. So that's the transparency for what we're receiving. Nonetheless, we're pleased that we have 10 QIAs that we can distribute across the network. We're pleased that we are able to put on this conference. And the parallel conversation has been with the payers in the marketplace this very message. Look, we've invested in TCPI and been fortunate enough to receive these resources, but it's not enough to transform the care. And we need partners to make that happen, especially we're looking at care coordination and care management, I think some of the personnel resources you're talking about. And the third piece I would say is that Enhance recognizes that we need a sophisticated data and IT infrastructure that supports all of our practices. And the owners of Enhance, those 9 founding members, say we're going to do this together because we can do it a lot less expensively than if we try to move that way on our own. And that's another major purpose for Enhance. So I think that I tried to answer your question. It looks like a big bucket of money, but when you split it all up and it comes down into, you know, the resources that Enhance has acquired on behalf of its members, it's just enough to get us started.
I can give you a little bit of a state health policy perspective on that. Nebraska could have easily been a SIM state, but because of the political brouhaha over the ACA, the administration decided that they would not even apply. We have a private agreement in Nebraska. That's called the Patient-Centered Medical Home Agreement, and I can give you more information about that. The 4 largest payers in the state have all signed it, and so providers can push payers to honor that agreement. The agreement itself doesn't have any enforcement mechanism other than we just keep meeting and talking about the progress we've made or not made, and the providers and the payers at the agreement table have been pushing each other to move forward with that. We have another opportunity in Nebraska now. If anybody has heard of CPC Plus, it's another federal grant. It's an extension of the current chronic care initiative, but it's going out to the payers, through the payers instead of necessarily state government, although state government has to be involved. And the largest payer in the state needs to be a part of that. So far, they're choosing not to. So there have been some missed opportunities for more federal funding to come into this. And if you want to know more about that, talk to me later.
And Margaret, can you introduce yourself?
Hi, I'm Margaret Buck. I am a new Enhanced Health Network employee, and I still work part-time for Senator Mike Glore, and he's had me working, excuse me, on the multi-payer initiative for patient-centered medical home for the last 8 years through the legislature. So that's where my knowledge of the stakeholder group comes from.
Thank you, Margaret. You know, listening to these comments, I don't want you to walk away overwhelmed here. There's been a lot of vision casting here, but I want to kind of go back to Mike's points, and I think they're a good thing to close with. Again, don't be overwhelmed with the work. This isn't a lot of new stuff. We need to figure out how to do what we've been doing different. Okay, so we got to figure out how we do it in an integrated way. We just need to figure out how we need to do what we do differently. Number 2, beware of the barriers, and it's going to be primarily the culture barriers. We're going to have so many people say, we just can't do that. We just couldn't do that. We can't even conceive of that. And when the answer is, well, you actually can, and you kind of have to. Okay. Number 3 on his deal was again, isn't it good that we can at least be doing this together? If we got to go down this pathway, at least we have the collective intellect, the collective experience here to try to figure out how we can go through this road together. And again, and I would add my 4th one, that there's never been a better time to suck with regard to the data. So don't be intimidated by the data collection. Get it. Embrace the transparency and figure out what you got to do as you go forward. Yes.
I'm Wendy Coliff, and I'm one of the quality improvement advisors here in Nebraska. And I have the advantage of working with practices and health systems as large as Faith Regional, all the way down to your smaller rural health clinics. And one of the things that I've told them is this is not a sprint, this is a marathon. And over time, as you mentioned, we are going to be looking at moving to more of a outpatient ambulatory type system instead of inpatient. And some of your resources will come from just the movement from that area, you know, to the more outpatient area. It's over a long haul. It's nothing that's going to happen quickly or fast.
Great comments. Thank you. Any other comments? Yes.
Just a piece of information for everybody as we've had conversation about patient-centered medical home and relationship with payers. I do know that Blue Cross Blue Shield of Nebraska is just about ready to message out across the state an opportunity to participate in their patient-centered medical home contract. And my understanding is there's 2 levels of this contract. There's one for those that have already gone on the journey, and there's higher level obligations with that, and there's also one that are just beginning. So the conversation I had with Blue Cross Blue Shield of Nebraska is, you know, it would be really great if we could marry up the work that's going on with the TCPI effort across the state and at least connect these folks to the opportunity that this agreement may bring to the table with Blue Cross Blue Shield of Nebraska. So that's a key piece of information. Maybe you'll keep your ears open for that and take a close look at that agreement with them, see if it makes sense for you at your community level.
Great. Thank you, Mike. Yes.
Hi, I'm Dr. Jonghyun Kim from College of Public Health, UNMC. Well, since we're talking about resources, I just want to tell you that we're here as a researcher, but as a helper, that because we are also very interested in improving our health in Nebraska and in nation. So we can be helpful in terms of the resources because we are searching for grants too. And then part of an example is that we have a lot of internal funds coming out in our college and in the Nebraska University of Nebraska Medical Center. Well, I was with the Dr. Hongmei Wang here. I don't know where Hongmei. Can you stand up? Yeah, she's a health economist. I myself, health management researcher. And then we were collaborating last year to use the internal funds from our cancer center and the College of Public Health to to find the factors to influence the colorectal cancer screening rate in working with SERPA ACO clinics in Nebraska. So this was, I think, was a really nice example to work how we academics could work with the practitioners to improve our health together. And also, plus using those preliminary data, we're still seeking for larger extramural funds. Those funds like from NIH or ARC, these could serve practitioners and clinics, who are lacking resources. We could provide some resources for them to hire more personnel, or maybe launch those new programs, or maybe help their IT. So also we could also provide some more resources for improve their health too. So I'm just letting you know that I'm here, also searching for partners too. Yep.
Thank you. I want to camp on this for a second because I met these two ladies during the break, but the fact that the College of Public Health is here, a couple of thoughts. Number one, your College of Public Health here has expertise in looking at the rural environment and trying to figure out how do we do this here. So I would encourage you to yoke with them. I know you're looking for unique projects, but that's, and again, I'm somewhat familiar through Keith Mueller over time with the expertise that you guys have here, and I'm happy to have you guys engaged in this. That's point number one. Point number two now is a challenge to you. We've got to find the messages and the ways that we can document the value in the rural environment and that is different than the rest of the world. So we need to continue to look at the impact of different, this is an economic, I guess it goes to you, but we need to continue to find ways of studying the economic impact as we transition from this volume-based to value-based system. And it's got to be, because honestly, we got to figure out what the sustainability is as we go forward. As we transition the revenue stream, and we deal with populations that are differently structured than everybody's concentrated in Pittsburgh type of thing, we're going to have to figure out how we do that. So anyway, thank you for saying that. Any other quick questions? Because we really need to slide to the next section. Rima, do you want to, or is just the next slide?
For the table talk?
Are we doing table talk now?
Yeah.
Okay.
So I don't think we have slides
Nope,
on it.
got to
if
pull it
just
up.
wanna
You want to pull that
introduce
up?
the questions. Oh, I don't have slides on the table talk questions.
Oh, you don't have them? Oh.
I didn't know there were slides.
Oh. Okay, let me get my, okay. We're going to improvise. This is like performance improvement on the fly. The first thing I want to kind of do here, okay, I hope you've had a chance to kind of look at the people on the other side of the table because you're going to work with them. This section is entitled Table Talk, and the guts of this was to try to have you now begin to develop into a network. I guess what I would encourage you to do, there are many of you with just 4 people at a table, I would kind of smush together so you got about 8 at a table. And what we're going to do is just, I'm going to let you loose in just a second here, and then I'm going to give you a question I want you to talk about among yourselves at your table, and then we'll just kind of gather some answers, and we'll see how much time we have. How much time are we doing this? 40 minutes? Okay. The first thing I want to do is just visually describe a thing, about resources that we have. And this is kind of, it's going to sound a little schmaltzy, but remember we don't know what we don't know? Okay, so if you look at resources, and if you do a 2x2 box, I'm going to try to do this in a way that isn't confusing to you, but it isn't confusing to me. But there's resources, and in this big pile of resources, if you do a 2x2 box, there's my resources and your resources, okay? So they're either my resources or they're not my resources. Got me? And they're either your resources or not your resources, okay? So if they're my resources and your resources, they're public, okay? If they're your resources and not my resources, they're yours. And if they're my resources and not your resources, they're mine. Got me? But then if they're not, they're not mine and they're not yours, we're in this other box where they're nobody's, okay? And the trick is, we don't have enough resources to begin with, and how do we begin to tap into this box? And this is, again, it sounds a little schmaltzy, but one way we can do it is you have stuff that I don't have, and I can make requests of you, and you can offer to give me what you have that I don't have, which is fine. It extends my box a little bigger. It makes the public box a little bigger. But the other thing is that I can offer you what you don't have, and I can move you into stuff that you don't have. And what happens on that 2x2 box is the requests expand down. As we expand the public box, we actually expand into resources that neither one of us have had historically. That's the guts of what we're trying to do here. We're trying to establish taking strangers and beginning to work together to try to talk about, well, we do this, how do we do that, how did you guys do this, what do you think, and just to begin a dialogue. So the concept of table talk, there's really two pieces. I mean, you could have a bunch of talking heads up here all day at you, but there's two places where we wanted to have you kind of begin to interact and build some network. This is one of them. So what I'd like to have you do, I don't have a slide up here that has the question, so I'm going to ask somebody at the table to write it down. So the first question I'd like to have you just discuss at your table is, what is your clinic doing to develop medical home capabilities? And so what I'd like to have you do is get together with a table of about 8 and kind of kick that around. And then what we're going to do is we're going to ask for people to kind of volunteer stuff, and then we'll kind of go to the next question. Okay? So, and we're going to do this till lunch. So you all can't hide in the bathroom for 40 minutes. Okay? So get to work, and we'll come back in about 10 minutes. How's it going? I feel like I'm looking at an airport here. I know, you can't look at the back of the room. Okay, how's it going, folks? Anybody, let's wrap your conversations up in about 30 seconds here. Well, that was 10 seconds. Okay, anybody have anybody want to talk about what they learned at their table, about what you're doing to prepare for medical home? Where are our kind of folks? Are you at lunch? Comments about medical home? You know, we were having a discussion on the side there a little bit ago, and oh, you got a comment? Oh, great.
Hi, I think at our table we were talking a lot about medical homes and trying to figure out how to get the patients involved, how they are going to see a benefit out of this. You know, they're all about cost, and if they're on a fixed income, they need to give up a med. So how do we get this information to the patients of what this benefit is to them to be involved in this patient-centered medical home?
Okay, so it's an interesting. Okay.
We have our chronic people that
Yeah.
we won't fill a medication because we haven't seen you for a year.
Right.
Oh, you're just trying to.
So some of this is this is a patient engagement discussion. What model will the patient-centered medical home bring, or what will the value be? How do we communicate that to our patients? Anybody have any comments on that? What the patients are going to see for value with regard to the patient-centered medical home? We just happen to have an expert in the room. So Dr. Klitgard, let me briefly introduce Don. Don's faculty with Compass PTN, but Don is a past board member of the American Academy of Family Physicians, but he was, and he's kind of recognized as he knows a lot about medical home nationally. Probably more important is he was doing medical home in his practice in Harlan, Iowa before it was cool. So for those of you who are intimidated by the whole concept of doing all this stuff, I mean, where do you start? How do you do it? Don's got a lot of great stories about, like, what's the first 2 steps you take. So Don, you have any comments?
Sure. Yeah, so just so you know, I'm a family doc. Practice about an hour east of here in Harlan, small town of 5,000, so very similar. I did my training in Lincoln at LMEF and spent a lot of time in the ERs and communities around Nebraska, so I have a close affinity to many folks in the room. So that's kind of some of my background. Our practice did the TransferMed National Demonstration Project, so it was kind of medical home transformation stuff back in 06 to 08 before it was actually called Patient-Centered Medical Home. So to answer your question specifically, kind of drawing on some of those experiences as we sort of gradually thought through what do we want to become. It was long before NCQA was around. There weren't check boxes. There weren't any of those kinds of things. It's much more of a philosophy and a baseline, how are we going to reorganize what we do as a practice? We had tried all kinds of small little practice improvement projects over the years. We'd actually tried to put in an EHR and failed miserably and went back to paper charts. I mean, we were a mess, right? And so we really wanted some structure, some philosophy, something to bring us together so that we could put some sense into how are we going to change how we care for our patients. And really, that's what the patient-centered medical home became to us. It was a common language. It was a structure. It was a way to talk about and think about things and communicate within our own organization, the providers, as well as the nursing staff, the front office staff, the patients, everybody. So to your question specifically, we didn't do a big, we're going to become a patient-centered medical home, and here's all the benefits you're going to see from it kind of campaign. What our patients, though, started to see is the low-hanging fruit for us, the first things that we really worked on are a couple things. We started to do huddles every morning with the docs and the nurses. So we would spend a few minutes at the beginning of every morning looking at our day and saying, all right, how can we better organize today? We've got three physical exams coming in a row at the afternoon. My nurse is going to need some help so we don't get behind. We've got a whole bunch of this happening, or this doc's going to be off doing nursing home rounds this afternoon so I can float over and help you. It was simple communication within the office stuff. It wasn't rocket science, but it made a big difference, and it made us more responsive to our patients. So what they saw was these guys were more organized about what they're doing when I actually come into the office. I didn't have to wait quite as long in the waiting room as I was used to, those kinds of things, right? We worked with our scheduling because that was a huge complaint over a long period of time, decades. I could never get into my doc. I call and I'm told it's going to be 2 weeks. So we spent a lot of effort up front trying to figure out access and how do we change how we look at scheduling and think about scheduling and simplify it for our schedulers. And we had to make some concessions as docs to not be quite so individual in how we wanted our schedules so that our schedulers could be more responsive to patients when they called in. So patients started to see, well, when I call in, I don't get that runaround quite as much. It's simpler. I can get in to see somebody sooner. Hopefully my practitioner I'm used to seeing. If not, they can get me into somebody else if I need to. So that was an early, simple change that we made. When you kind of start to talk about data, our diabetics started to see, we decided, first of all, we were going to kind of see what could we do with chronic care kind of stuff, right? We didn't know how to approach it. There wasn't tons of information out there then. So we looked at it and said, all right, we want to start with our diabetics because that's a big issue. So we made an Excel spreadsheet. Our EHR didn't have a registry functionality at that point. Many still don't actually, but we got a list together of our diabetics and started to realize that, we do a pretty good job when they come into the office. I know what to do as a doc. I do a good job when they're there, but I thought there was maybe 5% or 10% of my diabetics that weren't coming in regularly to be seen. Turned out it was 35, 40%. I didn't know it, we put out the fires when they came in. We took care of them well when they came in, but we didn't have a structure or a thought process or organization in place. So folks with chronic diseases, from a patient standpoint, we didn't do some big public relations campaign, but they started to see, I got this Jan and Betty. I kind of know them before. We put a couple health coaches in place to, kind of start to make some phone calls and connect with those folks that weren't coming in or had high A1Cs or whatever, and kind of dig into why that's the case and develop a relationship there. So they knew somebody wasn't the Wellmark nurse calling or the, somebody they didn't know. It was a familiar face that they knew in our office that connected with them. And so, some of those changes, I guess, were what the patients really started to see. And it didn't happen, boom, overnight. It was slow and gradual. But as we rethought sort of, how we could be more effective with our day, how we could make days better for our patients, but at the same time, be more organized. And so my nurse's days were better and more structured, and she had more help, and people were talking more, and it worked more smoothly. My day got better. I was, I was able to offload some of the things that I had historically thought I had to do, and we rethought through some of those processes, and there was a lot of busy work that I wasn't really good at. Somebody could do a whole lot better than me. Now I had to give that up. We had to work through that with the providers, right, of kind of letting go some of those things, letting somebody else do that, because they could probably do it more efficiently and a better job, and I could probably spend my time doing things more effectively. It took me a while as a provider, as a doc, to get used to that thought process of, in the end, I kind of got to the point where I realized that the value I brought was relationship. That's the key to all of this stuff, right, is a trusted relationship with the patient, and I was a key part of that. Not the only part of that, but it had to be a relationship with the practice, but that was a big part of what I could do and bring to the equation every day. And then managing complex diagnostic dilemmas and problems and issues and those kinds of things. I could still see simple things and all that kind of stuff, but my best use of my time was developing those relationships, making sure that patients felt like this was a place that they could trust, that they could rely on, that, they could believe them when we were telling them whatever we were trying to communicate to them, whether it was, about tough diagnoses or whether it was about prevention or lifestyle or all those other kinds of issues, right? If we had that relationship built, those discussions and all that stuff went a whole lot better and more effectively than if it didn't. So those were some of the early things that I would say our patients started to see and feel differently, even though it wasn't necessarily we put a poster on the wall. I mean, some of those things have been much more defined now, right? We were doing this joint principles of the patient-centered medical home. Those sort of grew out of some of the work we were doing in that, just as we sort of did it organically and learned from what works and what doesn't, and that kind of thing. So I would encourage you, as you're looking at patient-centered medical home stuff, I guess my couple thoughts for you would be, don't get overwhelmed. So don't look at an NCQA checklist or whatever and get frustrated and overwhelmed and say, we can't do that. That's way too much. You know, I'm taking on too much or whatever. You know, start simple. There are so many things that can be done in a practice to make your practice more effective, your care of your patients more effective and efficient, your lives easier, your patients' lives better, and that, you know, without having to look at some huge anonymous list that you think is just not able to be accomplished. So that's kind of thought number one. You know, the next thing I would say is when it comes to all of this stuff we're talking about with MACRA and ACOs and alternative payment models and all that kind of stuff, don't be scared of that. And I would say the stuff you're talking about right now, the medical home stuff, the way I looked at it when we looked back at it in our practice, that was getting our house in order. That was really teaching us to figure out how can we do what we want to do for our patients right. Why did I go to medical school? It wasn't to practice medicine like I'd been practicing medicine for the first 10 years of my practice career. It was this medical home kind of stuff really got us back to what I wanted to do, the kind of relationships I wanted to have with people and the kind of impact I wanted to have on our patients' lives and the community we were practicing in. That really got us focused back on that stuff and stripped away a lot of the other things and really got us focusing on the right stuff. And I'll tell you, because in addition to my faculty job, I do a lot of ACO work in Iowa right now, and I'll tell you that ACOs, alternative payment models, those next step kinds of things that are coming, and they're here to some degree, but they're going to be building and becoming more popular and more numerous down the road, that stuff is not going to work unless we do this medical home stuff right. I mean, this is foundational. You got to do this stuff and get that stuff organized if those ACOs are really going to be effective. If it's just chasing dollars and just looking at data and it's not organized around what's right for the patients, what's right for your practices, how do you do that stuff and do it well, that's really got to be the foundational truth in a lot of this kind of stuff. And then the rest of that can grow out of that and be really effective. But I guess those are initial thoughts on that.
Thanks, Don. I just want to capture a couple of things, just to underscore a couple of things you said, and then I actually want to try to do one more question before lunch. But, you know, Mike and I were talking a little bit ago, and we want to make it, this is real clear, that this whole thing isn't about medical home, okay? But medical home is a model that really kind of helps us reorganize our work. And I think Don did a great job of kind of presenting a vision of care delivery that's patient-centric, and it uses data differently, and it organizes the way we do things differently. So patient-centered medical home, again, the project isn't all about it. It's presented to you today primarily as a model that helps us that's kind of what we're working toward. It kind of embeds a lot of the things that we need to do as we go forward. The other thing is that Don kind of alluded to is that, you know, our payment methodology is changing, and basically if the medical home is a discussion about how do we organize our interactions differently and care delivery differently, we got to figure out how we're going to do this payment thing differently. So the MACRA, and you've had quite a bit of information on the MACRA today about what it is and it's coming down the road, what the metrics are. So what I'd like to have you do at your tables now, instead of talking about what we're doing to prepare for the medical home, I think what I'd like to have you do is discuss just at your table, what are we doing to prepare for MACRA? Okay, so just going to give you about 7 or 8 minutes to talk about that, and then we'll wrap with that discussion. So what are we doing to prepare for MACRA? What is my clinic doing to prepare for MACRA? Okay. We got, I know you're just counting the minutes. You've got about 7 minutes before lunch. So we got your juices flowing here. With regard to MACRA, anybody want to share any of your thoughts? What are you doing to prepare for MACRA? Questions about MACRA? Yeah, so the comment was we didn't really know too much, so we came here to learn more about it. Are you learning? Are you ready to kill yourself? They didn't say yes, so that's... Yes, we're learning. Yeah, well, yeah, we'll wait until the conference is over. Okay, other thoughts? MACRA. You know, one of the points, somebody's already brought this up in a breakout here, but how many rural health clinics do we have here? Oh, yes, and you're all going, well, yes, that's very nice for you. But we really don't have to play that game, so we're so glad we are what we are. Right. Okay, just a reminder, I just want to tell you about the South Dakota discussion. So for the rural health clinics in the room who are going, well, this isn't our game. There was a discussion in South Dakota where, first of all, the status with regard, let's just talk about MACRA for a second. This gives us a chance to kind of kick this around a little bit, but MACRA's been released. It is out in law. They now have to write the administrative rules that will determine how it is executed. And the first set of administrative rules have been written and released, and they're out for comment currently. And in the current venue, the rural health clinics are not included. So, gee, a good deal, huh? Move forward. We're okay. The discussion that happened, and my bias is, I'll just tell you right now, is that, yeah, not now, but, and I think there will be application at some point. The discussion that happened in South Dakota was, it was really kind of a heated discussion where there were a couple of rural health clinics, and then the head of the rural health clinic organization. Is that person here today from Nebraska? Okay, you guys don't have like your head of the rural health clinic organization. Okay. Well, this person was in the room, and she was really taking an advocacy position. She said, well, you know, this doesn't apply to us, so why would we do this? And, you know, she's really kind of speaking for the community that we, the rural health clinics, don't have to do this stuff. And then there was one of the rural health clinic people just basically kind of said they were just observing it. But the other one basically stood up and said, you know, they aren't going to allow us to be a separate standard of care of the rest of the world. We have a reprieve with regard to execution, but the fact of the matter is we're gonna have to go there at some point. So we at our clinic are going to embrace this and try to figure out how we can play as quickly as we can. And the reason I also hold that position, but I think an analogy to that is the typical critical access hospital. You know, there are three flavors of hospitals. There's PPS, and there are large and medium-sized PPS hospitals, and then there are the critical access hospitals, and I know you have critical access hospitals as well. Iowa is a very heavily penetrated state for critical access hospitals. We have 118 hospitals in Iowa, and 82 of them are critical access. So we're your like prototypic rural distribution. We're like homogeneously disseminated sparsely across our whole state. And the question is, if you're a critical access hospital and all this payment reform stuff that's happening at CMS, well, why would we do this stuff? If we don't have to do it, why would we do it? I mean, we're critical access hospitals. We don't have to do this junk. And I've been telling the hospitals for about 3 or 4 years, your PPS hospitals are incented they're not going to get paid if they're not doing this patient safety care coordination stuff. So their standard of care continues to raise. And my point with them is you better also be raising. Because the problem is, if you have a certain payment system that guarantees you a standard at this point while the rest of the world is moving, and if we know that we're going to go through revenue contraction, if I get to the point where I have to do revenue contraction and I have the high quality and I have the not high quality, small, not high quality, I wonder who I cut. Now, I would kind of be looking at, and I would apply the same thing to the rural health clinics. We are there for a unique reason, but I don't think we want ourselves to allow ourselves to be in a model that is not viewed as the standard of care. So, no, you don't have to, but I'd sure recommend it. Other macro comments. What are you doing? What are you doing? You doing anything? You reporting to PQRS? Okay. How's that going for you? Are you guys dead? Yeah.
We're an anesthesia group, so we're trying to figure out where we fit in all this, because it's really a square peg in a round hole. And so we're trying to do registries with QCDR and QR, reporting PQRS, and the rules and the regulations are written in a way that they contradict themselves. It's really hard for a specialist group like ours and you know, we can't be part of a primary care medical home because that's not our specialty. We see
Right.
patients that day, and then we're done. You know, we don't see them later. We can't follow up and tell them not to smoke or
Right.
whatever. So we're doing all we can with MACRA and trying to figure it out. And anesthesia may be exempt from the meaningful use with radiology and pathology, which is probably appropriate because there's no way we can meet those measures. And but the same things with the PQRS. The measures are real. You know, I hate to use the word stupid, but they're really stupid and have nothing to do with true quality care.
Yep.
Especially for anesthesia. And so we're trying to do everything we can, but we're really having a hard time figuring out where does anesthesia fit. And I think the government doesn't understand it. They're trying to take a one-size-fit-all primary care system and make it work for us. So that's why I say square peg round hole,
Okay.
and they aren't getting it.
Well, first of all, I want to thank you for saying something. You actually teed up another point that I wanted to make. But first of all, we have a fairly high percentage of specialists in the Compass PTN. There's a high percentage of specialists in the Nebraska, in the enhanced model as well. And you kind of go, well, wait a minute. What is this? How does this work for me? So I would say, first of all, I want to kind of go back to the practice assessment tool. Well, before I go there, and I'm a primary care doc, but I would kind of, if I could choose what I'd rather be, I would probably be a specialist. I would rather be a specialist right now. Don't let it go to your head, okay? But primarily because of the limited scope of application. You have a smaller scope. The primary care folks have got to, anybody old enough to remember the Ed Sullivan Show? Okay, the Ed Sullivan Show, there used to be this guy that would have these, he would do these plates, and you have like 5 of them going on these different, the primary care has got to do stuff like that. Now that said, it doesn't mean you're off the hook. You still have to do this stuff. In the practice assessment tool, I neglected to say this earlier, but the practice assessment tool, there are 2 versions. One version is for primary care, the other one is for specialty care. So there is a change package of applications that are kind of tailored to specialty care. So when you guys do a practice assessment tool, it's not like medical home 101 stuff, but it's basically looking at things that are going to be more relevant to your, germane to your practice with regard to sustainability and all that kind of stuff. So now that said, you still got to do it. And we still got to figure out how to do it. And I wish I had all the answers, but I don't. All I can tell you is the fact that they've written a practice assessment tool that's aimed at specialties tells me that's important. And number 2, I kind of would rather be in your situation right now. But again, we've got to figure out how do we come together and block together in a big medical neighborhood. We got to have anesthesia, and you got the challenges everybody else does too. I wish I had all the answers on deployment, but they're still writing the administrative rules. Thank you for that comment. Other questions? Other comments? Yes, Mike?
can't help myself. I have to respond to the question from my specialist colleague as they're wrestling with how they fit into this. I scribbled a couple notes down. You know, my thought has been from the beginning that one of the lines of questions we should be asking ourselves is, the primary care providers in the future world, all the patients are being attributed to them. And all the scores, the cost and the quality, is being attributed to those primary care providers, as I understand it. So there is an opportunity for especially colleagues and the primary care doctors to work together on metrics that will impact the, quote, quality score or cost score for that patient. So thinking just immediately through my limited understanding as an anesthesiologist job, because I'm a general internist and I'm hampered by that scope. You know, there's access issues for patients that have to come in to have surgery. And does that access delay their care? Or is it hard to get in? I think anesthesiology may have a role to play in that patient experience metric, if you will. It's difficult for me to get my pre-op evaluation. There's cost implications depending on what you've standardized for your pre-operative care. What tests are you ordering? Are they evidence-based? Can you assist your primary care provider or your orthopedic surgeons that are involved in bundled payments? Can you assist them in reducing the perioperative cost by standardizing the care processes as they flow through anesthesia? And clearly, the work that our anesthesiology colleagues do has significant implications for safety and harm, true safety and harm, not always the things that gets coded out in our system, but bad things can happen if the care is not managed well by anesthesiology, and it has enormous implications for cost and quality as well. So those three things, just off the top of my head, I know that those may not be measured by PQRS. I know that that doesn't maybe fit in with patient at a medical home, but to Tom's point, I think it would be prudent for us to realize that everybody's going to be in this environment, and the specialists have a really critical role to partner with the community and the primary care providers to deliver the kind of high quality, low cost care that they're going to be held accountable to.
I just want to play off of one thing on that, and then we're going to have Rima tell us what we're going to do for lunch. But I agree with everything that Mike just said, except there's one additional thing I saw literally yesterday, or day before yesterday. There's a measure that's, and again, remember we don't know what we don't know, and remember that a lot of this stuff is developing. We have the macro right now, but there's a lot of discussion going on about how do we do value, and how do we, and there's a number, you know, the definition total cost of care. And Mike kind of alluded to the fact that the total cost of care is going to be attributed to the primary care physicians. And imagine they're going to have to actually, I mean, when you're looking at the total cost of care for a situation, it's going to be, the physicians are going to be kind of responsible for kind of looking at how do we do this and all these different components. And Mike made the statement that it's pretty much the primary care folks are going to be tied to the total cost of care. And I saw a model yesterday from Health Partners. And this it's an open source model that Health Partners uses on total cost of care. They're working to develop this measure, but and it's the only total cost of care measure that's been endorsed by the National Quality Forum. So this is pretty mature, and it basically is now. They have a. I'm not describing this well, but there are like 6 different buckets on how the care actually goes through the deal, but there will be 2 attribution points. Merry Christmas. But the primary care physicians for one segment will be attributed, and then there will be other specialists that are attributed to the total cost of care. So for example, if this is a cardiologist who initiates a whole chain of things that are happening, that cardiologist is going to be responsible now for a total cost of care piece. So I guess the guts of this is, to the physicians in the room, there will be total cost of care discussions and attributions to us, and we're going to have to figure out how do we play in that deal. We are responsible now. MACRA is just the next chapter in how we move toward value-based care, but I think we're beyond just delivering medical care. We're going to have to deliver now stewardship as we deliver care moving forward. So let's stop here. I want to thank everybody. It's been a great audience. We've done a great job this morning, great comments. Let's turn it back over to Rima for lunch.
Yeah, thank you, Dr. Evans. So we're gonna break for lunch. Lunch is until about 12:45. It'll be served right outside here where breakfast was. Also, if you did have any specific dietary restrictions and requested a special lunch order, Joan is at the registration table this morning where you registered. Go see her and she can make sure you get your meal. Thanks.